Thank you so much. Good morning, everyone. My name is Stephanie, and I completed my practicum with the BC Center for Disease Control. Before we begin, I want to acknowledge that I live, work, and play on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh First Nations. I wanted to thank Dr. Jonah Rosali, all the members of the BCCDC, as well as Victoria and Biddy Taylor for their support in getting me to and through this practicum. A little bit of context before we begin. BC has a lot of health data, and until last year, the smallest level of dissemination for some of it were the local health areas. It was pointed out that even this level of data wasn't always representative of all the diversity of BC communities. In order to better understand, address, and plan for current and future health needs of communities, it was decided that a smaller boundary was needed, hence the creation of community health service areas, or CHSAs. The ministry also commissioned the creation of 218 new health profiles, one for each CHSA. The profiles would contain basic demographic, health system, and health status information, and would also serve as a tool in the creation of primary care networks in BC. My practicum with the BCCDC focused mainly on supporting the development of the CHSA health profiles. One element I struggled with early on was integrating my work with the health profiles, with public health and primary care networks, and making sure it was all comprehensive enough for my graduate project. Figuring it out was like putting together a puzzle with one piece missing. I wanted to find a connection and showcase the profile's value in population health and service provision. My research led me to a component of primary care networks called the community health centers, Cs for short. Like primary and community care centers, CHCs offered basic medical care, but what defines them is their focus on health prevention, promotion, and community development. This model of care integrates clinical care with programs and services that focus on the broader determinants of health. CHCs are run by boards of community members and exist to serve an identifiable community. The centers are not-for-profit and often operate through alternative funding models as opposed to fee-for-service. Community and social service provision professionals are also employed at the centers themselves. And because the services are available in-house, it makes the referral and communication process for patients a lot easier and often more results in more holistic, accessible, and comprehensive healthcare experiences. Now, CHCs have been highlighted as a big part of primary care networks in BC. Progress on their development has been slow. This was my missing puzzle piece. My project would focus on evaluating this model of care and talking about how the community level data of CHSA health profiles would fit into the development of BC CHCs. To evaluate this model of care, I looked at the history of CHCs in BC and in other jurisdictions. They were popular in Canada in the 1970s, and communities were approaching governments with their unmet health needs, and this was leading to development of community-run health and service centers. However, as with all ventures involving politics, changes in power had system-wide effects. So changes in the political climate in BC after the 1970s, as well as opposition by the BC Medical Association at the time towards alternative funding models, meant that BC CHCs eventually lost momentum and support, and many, but not all of them, actually closed down. But even though BC CHCs lost momentum, Ontario CHCs actually thrived because the Ontario government saw their value and their potential. Over time, a model of care was developed, and is now known by the Alliance for Healthier Communities as the model of health and well-being. The Alliance represents over 100 community-governed primary healthcare centers in Ontario, the majority of which are CHCs that have all adopted this model of care. Evaluations done on the programs and services offered in Ontario CHCs have shown that they have contributed to reducing health disparities and inequities within Ontario governments. For example, the London InterCommunity Health Centre developed a diabetes program that included early screening of high-risk populations, primary prevention efforts, and timely follow-up. Patients were encouraged to attend self-managed clinics and had access to resources that addressed their non-medical problems that were affecting their diabetes. An assessment of the program showed a 10 to 20% decline in cardiovascular risk within the community, an indication that people were responsive to the health promotion and prevention efforts. Ontario CHCs that have been successful in meeting unmet health needs have seen better health outcomes. They've seen reductions in everything from predicted healthcare costs to levels of social isolation, especially in vulnerable communities. For instance, Regent Park is Canada's oldest public housing project, and the residents there are often faced with a multitude of barriers to proper health care and social services. Regent Park CHC identified education as a major determinant of health for the children there, and with the support of parents in the community, they launched the Pathways to Education program. The purpose of the program was to provide academic, social, financial, and advocacy educational support for children in the community. An evaluation of this program showed that Not only were there lower high school dropout rates and higher attendance rates, but the college and university enrollment rates of graduates increased from 20 to 80%. It was estimated that for every dollar invested into this program, there was a $12 return. CHCs and this entire model of care have made some invaluable contributions to Ontario communities, and it makes sense to want to do the same for BC communities. The second part of my report then focused on how the health profiles I was working in would help develop CHCs in BC. It's clear that in order to establish a successful CHC, it was essential to first understand the unique health needs of each BC community. CHSA health profiles would provide demographic data as well as information on various health indicators, social determinants, and health status of individual BC communities, as the profiles are intended to serve as a tool of community health data. Since the profiles are comparable across neighboring communities as well, the data can then be used to decide on services and programs that may offer benefits to more than one community. For instance, if a neighboring community shows high unemployment rates, this information can then serve as a catalyst towards employment programs in a CHC in that area. The profiles will also play in anticipating future health needs of community, since they'll be updated as data becomes available. Profile data can be used to identify health trends within the community and then to guide direction for service provision. Since the CHSA health profiles are created using data from Stats Canada and the ministry, among other sources, this makes them a high quality and reliable data source that will contribute evidence-informed decisions regarding CHCs and the health of BC communities. Finally, it's important to remember advocates and peers engaged in the CHC development process may not be healthcare professionals. In order to make sure that all individuals are given equal opportunity to participate in advocacy activities, the profiles are developed with the community in mind. Information is communicated in a way that's understandable to professionals, community organizations, and peers. Taking into consideration that CHCs operate through alternative funding models, it's also imperative that these advocates can comprehend the health information, be able to present it back to potential funders and stakeholders. As my report wasn't an extensive one, there were some things to consider. CHCs in other jurisdictions, for example, and their operations as well as their available health data may be different. So further exploration into this aspect may actually prove beneficial for BC CHCs. It's also important to remember that the profiles only play a supporting role, and they're limited to the contribution of local health data in CHC development. BC communities are diverse, and there may be certain demographic or cultural differences that might not or just cannot be accounted for in the current scope of the profiles. The CHSA health profiles are still in development, and it's likely that the health indicators included are not all inclusive, and that all the indicators that would give us the health and well-being of, or a good idea of the health and well-being of BC communities. However, CHCs are an important but undervalued model of care. In order to support their development in BC, it's imperative for stakeholders to be able to access a reliable and high-quality source of community health to understand and identify the unique needs of each community. The CHSA health profiles will hopefully play a big part in providing reliable and accurate health data and contributing to the development of CHCs that will provide the quality of primary health care that all BC communities do deserve. So that's the end of my presentation. I hope that everyone enjoyed it, and feel free to ask me any questions now.
Thank you very much, Stephanie. And right, actually under 10 minutes, so that's great. And again, the comments are coming in. Are there any questions? Actually, I'll have one before I'll just hop in there. In terms of just the funding and the costs, I mean, I know they're quite varied, the CHCs, but what sort of funding would be required for, what sort of the range of funding required for these CHCs?
So actually, I did a little bit of research on this in terms of like the political aspect, and the current government that is in power in BC, so the NDP, they've actually made a commitment to build 20 new CHCs within BC, as well as to support the ones that are currently existing. There's not that many of them, but I believe that the commitment was for 20 new CHCs, and the number escapes my mind right now, but it's there's a certain amount of money allocated to helping their creation in BC.
Well, that's good news to hear that. Excellent. Sanjeet, do you have a question?
Sorry, I may have missed this because here in Edmonton, we have primary care networks that are pretty much huge, and we have multiple ones. So is this similar to a primary care network, or completely different, or does it kind of take parts of that primary care network into consideration?
Well, CHCs in BC are intended to be one part of the primary care network that we're trying to build here in BC. The other part being just primary care centers that would offer primary medical care, as well as like urgent care centers that would offer like, like emergency care and things like that. And all of it, I think, is to help build more primary healthcare within BC, and hopefully to get BC residents to a point of where they're using, fewer emergency visits, and there's more people staying healthier in their communities for longer. But CHCs are intended to be a part of that entire network.